This is Dusty Lynn, and I am the pediatric educator at the Life Support Learning Center. And today we're going to talk about shock in the pediatric patient. This is a brief overview, and I hope you'll join us for our in-class sessions where we have much more depth and discussion to our content. So our objectives today are to identify the four main types of shock in the pediatric patient and to be able to identify two key assessment findings that indicate the child might be in shock. And hopefully you'll be able to recognize that it's in the key assessment points and in their history that will help you understand what type of shock they're in. Here are the categories we'll be discussing: hypovolemic shock, distributive shock, cardiogenic shock, and obstructive shock. Today, for the purposes of simplicity, we are going to talk about septic shock as part of the distributive shock group. However, it is often discussed as a separate entity because it is a very different type of shock in and of itself. You may feel this way when you realize that you're going to be taking care of a child who's very sick and could be in shock, but hopefully, again, by the end of this presentation, you'll have some key points to help you in that bedside assessment. Recognize that children are not just small adults. Their responses to illness, to trauma, diseases can be very different than the adult. Don't go by memory and trying to remember, gosh, a 6-month-old weighs about this much and his heart rate is about this versus a 3-year-old. Just carry a good reference that works for you. There's a lot of good references out there, so find one that works well for you. Things that you might want to have readily available to reference would be weight estimation, vital signs, certain equipment sizes, medications, and review. Brain science tells us that the more we review something, even though we haven't had that situation in the past, if we review it over and over, then the first time we have to make that response is as if we've been trained to do it before. So again, use your brain, review. So the definition of shock is really an intricate balance of what the cells need and what the cells get. So we'll talk about all the different things that could change that either way, but that's really the bottom line. You'll see in the literature DO2, delivery of oxygen, which is all about that delicate balance of getting the cells what they need between the oxygen content and the cardiac output. That is what equals a delivery of oxygen to the cells. It's very important to recognize that shock is a progressive state. They can get metabolic acidosis, and once they do that, the organs don't function as well as they should, and that can lead to death. So recognizing it way before then, very important. We'll talk about the categories of shock, and we'll also talk about the severity as well. So in general, if a pediatric patient is in compensated shock, all that means is that for the moment, their absolute essential organs are being perfused, but it is at the expense of the non-vital organs. So they'll have shunting going from their bowels, so to speak, to make sure their lungs and their heart and their brains are perfused, and their blood pressure will be normal during this phase. They're still in shock, but they've shunted their blood. They have the cardiovasculature that allows them to do this, and they can reallocate their perfusion to keep the central organs perfused, and their blood pressure may still be okay, but they're still in shock. By the time they drop that blood pressure and they become hypotensive, then all of their organs are underperfused at this point, and if we don't rapidly intervene, they could lead to irreversible shock, which ultimately leads to death. Here's another way of looking at shock in the pediatric patient. You can have deficits in their preload. They just don't have enough volume. You can have challenges with their plumbing, so to speak. In distributive shock, they're all vasodilated, so their tank gets bigger. You can have problems with their pump. Their heart itself just can't move the blood around the way it should, or you can have an actual physical obstruction to the blood flow, an obstructive shock. Just remember, it is definitely a continuum. They can be in shock and it's compensated because their blood pressure is okay. They're still in shock. By the time they drop their blood pressure, they are uncompensated shock, and it will rapidly turn to irreversible shock if we don't intervene. Here again are our categories, and we'll talk about each one. The assessment of shock is really all about that hands-on ABC assessment, and we have another presentation about that, but this is again what you see, what you hear, what you feel. I cannot overemphasize the importance of a good hands-on ABC assessment in the pediatric patient. It will tell you more than just what numbers on a monitor will. So your systematic assessment, again, join us for that presentation as well. But briefly here, just remember that any child who has a decreased level of consciousness has a threatened airway. When they lay down, that big tongue, oftentimes the muscles that hold that tongue out of the airway, if they are lethargic, those muscles are also lethargic, so to speak, and that tongue can drop back in their airway and cause obstruction. So even though the airway is not the issue in a patient who is in shock, it can certainly become an issue if we're not paying attention. So always, always address the airway, and then assess their breathing. What are their bilateral breath sounds? What is their respiratory rate? How hard are they working to breathe? And you'll notice, again, a continuum where initially they may be okay, and then they start to work harder or breathe faster, and these are indications that they are decompensating. And what is their circulation? Don't forget that the brain is a good indicator of what their cardiac output is. So if they have a decreased level of consciousness, it could well be because they have decreased cardiac output to the brain. What is their heart rate? Heart rates in the pediatric patient are very sensitive. It's one of the first things that change when they're sick. And what is their rhythm? You have to recognize the difference between sinus tach, that might be a compensation for shock, versus an arrhythmogenic event where they're in SVT, which of course is treated totally different. So you have to recognize that. What is their skin temperature? When you put your hands on their toes, are their toes cool? Put your hands on their ankles. At what point do they start to get cooler than their core perfusion? And recognize that as an ongoing assessment. What is their pulse quality? Compare their central and distal pulses. Again, this is very unique in the pediatric patient because they have pristine cardiovascular systems in general, and they can compensate by clamping down or vasoconstricting and reallocating that perfusion. So if you have a central pulse that's weak in the pediatric patient and you don't have a peripheral pulse or a distal pulse, usually they are hypotensive at that point. So again, check the central and distal pulses, compare the quality, the skin temp, and of course their capillary refill. So our cardiovascular perfusion, what is their level of consciousness, what's their output to the brain, compare the pulses, skin temperature, capillary refill, and recognize that capillary refill, we know over 2 seconds could be abnormal. Certainly 3 seconds or more is often abnormal, but also recognize that a flash refill of 1 second can also be abnormal. It could mean that they're peripherally vasodilated and all their blood flow, or a lot of their blood flow, is in the tissues instead of in the central or the core perfusion. So capillary refill, very good indicator of what's happening in a pediatric patient. And your heart rates. You have to know the norms. You have to know what's normal for an infant when they're awake, when they're sleeping, a toddler, etc. And you have to know what the extremes are as well. So your heart rate in the pediatric patient, again, carry a card. This is something that's hard to remember if you're not used to seeing kids a lot, but it's very important to know your red flag extremes. 180 or 220. In a resting child, say a child who's 1 year and over, if his resting heart rate is over 180, you have to rule out a abnormal cardiac rhythm. That could be SVT. And knowing that is very important. That number in an infant, if they're less than 1 year, is 220. So if a resting heart rate in an infant is over 220, you need to rule out a cardiac rhythm disturbance, because if you start treating that child like he is in hypovolemic shock and you start pumping fluid in him instead of correcting his dysrhythmia, you could be adding more problems and causing more harm than good. So you have to recognize that. And certainly we know in the pediatric patient whose heart rate is less than 60 and they're poorly perfused, we want to oxygenate and ventilate. And if that heart rate doesn't immediately come up, we're going to start CPR. So you have to know those trigger numbers for sure. Blood pressures in the pediatric patient, very different than the adult, because as we said earlier, a pediatric patient can have a normal blood pressure and still be in fulminant shock. You have to have the right size equipment. If you have a cuff that's too big, you're going to have an erroneously low blood pressure. If you have a cuff that's too small, his blood pressure might look like it's fine. And in reality, he's hypotensive. So again, recognize that the child can be in shock with a normal blood pressure. So hands on that patient. Central distal pulses, capillary refill, what's the skin temperature? All these are indicators that the child could be in shock if they are abnormal. So physiology in shock stages can be different in the pediatric patient. They're more likely to be in cold shock than warm shock, but they could have both. And so when you think of cold shock, you think of that mottled, long capillary refill time, decreased pulses. Warm shock, they can have bounding pulses. They could have that flash refill of 1 second. They can have wide pulse pressure. So just recognize that not all shock is going to manifest with a decreased cap refill and weak pulses. Here are examples of prolonged capillary refill in the pediatric patient. This child on the right was in cardiogenic shock when this picture was taken, and his capillary refill was like 9 seconds. His blood pressure was normal, so he had a normal blood pressure, but his perfusion looked like this. And that child had died in less than an hour. So you cannot go by blood pressure in the pediatric patient as indicated of shock. So in general, when we talk about shock, and you're going to see this repeated because these are the goals for improvement of delivery of oxygen to the tissues and to the cells. We want to optimize the O2 content and optimize that delivery of the content. We want to improve our volume and our distribution of cardiac output. We want to reduce how hard the heart has to work, reduce the O2 demand. And certainly if there's any kind of metabolic derangements, we want to correct them. And our whole goal, of course, is to prevent permanent damage and cardiac arrest. And again, these are just general guiding goals when we're talking about shock management in the pediatric patient. So let's talk about hypovolemic shock. In general, here's some guidelines of how much volume a baby to a child may have per kilo. If you look at that and realize it's not much. A 5 kilo baby has less than a water bottle, a 500 ml water bottle, or can of Coke is like 380. So a 4 kilo baby has about the same amount of volume as a can of Coke. So recognizing that they don't have a lot to lose. So there's two main types of hypovolemic shock, hemorrhagic and non-hemorrhagic. Hemorrhagic is usually obvious. They have a history of trauma or some kind of break in integrity of the vasculature. It's not always obvious because if they have internal hemorrhage, you may not recognize that they have a liver lac and they're bleeding out from that. Again, it could be trauma. It could be non-accidental trauma, and they come in with seizures. And you don't recognize that it's a multi-trauma because they've also been beaten. So they could have non-hemorrhagic shock, which is the most common type of shock you'll see in the world for pediatric patients. It's usually a GI thing. They've lost something out, nausea and vomiting, diarrhea, those kind of things as well. And that usually means they've lost something out into the environment. So the problem here is they don't have enough preload. The heart's not getting in the volume it needs. So the ventricles aren't getting enough volume it needs. So when they go to squeeze and put out, they have decreased stroke volume, which ultimately ends in decreased cardiac output, which means the cells aren't getting enough flow or volume that they need. So the signs and symptoms of decreased cellular perfusion is pretty much uniform in the pediatric patient. They usually shut down distal to central or peripheral to core as they're reallocating their perfusion. One of the first things that happens is they increase their heart rate. They're just trying to move around that volume more because it's limited. Their mucous membranes can be dry. They can be tachypnic. They can have sometimes increased contractility initially as they're compensating, which then gives way to poor perfusion, delayed capillary refill. Their skin could be cool, decreased pulses, and decreased cardiac output to the brain, and decreased urine output. Again, hypovolemia. They don't have enough volume. So what do? Here's our treatment goals. Of course, we want to stop the loss, depending on what the loss is. Sometimes it's a surgical intervention. Sometimes it's a GI intervention. But whatever reason is causing them to be hypovolemic, you want to stop that, of course. You want to optimize the cellular perfusion. Sometimes you have to give them high concentrations of oxygen, and sometimes you need to ventilate them if needed, or make sure they have enough oxygen, hemoglobin carrying blood if they need that, and you need to fill the tank. We're going to give volume. It's usually 20 cc's per kilo of a crystalloid. If this is a trauma patient, as soon as you can get them blood, if they have ongoing loss, that's what they need. Packed cells, we're going back now to whole blood, which is great in a lot of facilities, and so that would normally be 20 cc's per kilo as well. And look for ongoing loss if they don't rapidly correct. So we want to reduce how hard the heart is working. If they have fever, we want to treat that. That just makes the heart work harder. And if they need ventilatory support, support that. And of course, correct the metabolic derangements, because regardless of why the child's in shock, if they're hypoglycemic or hypocalcemic, the heart is not going to work as well, certainly if they're hyperkalemic. And if they're acidotic, especially in the hypovolemia, you need to continue to give volume. So oftentimes we're watching the lactic acids of these patients, and if they maintain an acidosis, it means the cells still don't have enough volume and they're not quite yet euvolemic. So let's briefly go over distributive shock, whether it's warm shock or cold shock. The tank gets bigger. So distributive shock, the common denominator between them all is they are vasodilated. There's a maldistribution of perfusion. And we'll talk about septic, anaphylactic, and neurogenic shock. So again, the general treatment goals are the same. You want to stop the spiral, whatever's causing the distributive shock, you want to stop it and optimize the O2 content in the blood. We want to fill the tank, and in the case of distributive shock, we want to shrink the tank. We want to reduce how hard the heart has to work and the O2 and metabolic demand. This is very important in distributive shock. And of course, we're watching for any kind of metabolic derangements and improving those as well. Under metabolic acidosis, usually the answer is improve their delivery of oxygen to the tissues, and that will turn around the acidosis. We don't routinely just give bicarb. You change the number, you don't change the physiology, so oftentimes we look at other things to do that. So anaphylactic shock. It is an acute, severe systemic reaction to an antigen. Sometimes it's known or not. Again, it's more than just a allergic reaction. In anaphylactic shock, now the cardiovascular system has gotten involved and is vasodilated. So your clinical assessment, they could be agitated, they could have anxiety, angioedema, as evidence in the previous slide. They could be working hard to breathe. You could hear upper airway issues in stridor or wheezing in the lower airways, and their heart is oftentimes racing. And again, by the time they become hypotensive, they are in anaphylactic shock. So we want to increase the O2 just like the other types of shock, O2 delivery to the tissues. Sometimes we have to do that with bronchodilators and oxygen. The bottom line is an anaphylactic shock is pretty much a simultaneous response, but you want to get that IM epinephrine. If you look at the current studies, kids who don't do well from anaphylactic shock, it's oftentimes because there's been a delay in giving the IM epinephrine. So that's one of the very first things that you're going to do as well. And again, you want to reduce the O2 demand and correct metabolic derangements as well. Neurogenic shock is a sudden loss of sympathetic tone because of spinal injury or head injury. Here is a very different, it's the only shock in the pediatric patient that we're talking about that is not the normal tachycardic and poorly perfused or altered perfusion type of response. In neurogenic shock, they can't mount that tachycardic response. So they're bradycardic and they're peripherally vasodilated. So oftentimes the dependent extremities can be very warm. So that's the hallmark of neurogenic shock, is that they're bradycardic and vasodilated. They have a wide pulse pressure before their blood pressure becomes hypotensive. Treatments are your ABCs. Position the patient flat if you can, in the head or head down. Depending on what your protocols or orders are, you may well need to give them volume as well and vasopressors as needed. Again, the hallmark of neurogenic shock, hypotension, bradycardia, and warm skin. Sepsis itself is a different beast. So let's talk about that. And it is definitely a life-threatening organ dysfunction caused by a dysregulated host response to infection. It's inflammatory response, infection, and cardiovascular dysfunction. The bottom line is not only do they vasodilate, which makes the tank bigger. So now you have this vasodilation, tank gets bigger, so they automatically don't have enough volume because the tank gets bigger. And in septic shock, because of the cytokine release, what is in the tank starts to leak out. So they have capillary leak. So that's another reason why they have decreased volume as well. So when you think about that, lots of reasons why they can be hypovolemic just because of the mechanisms of vasodilation and capillary leak. Decrease delivery of oxygen to the cells is the end result. They're medical emergencies, and again, clear and early recognition, very, very important. If you look at the current shock recommendations, that first 5 minutes after recognition, very, very important. So we want to optimize the O2 delivery and content to the blood. Oftentimes they need to be on high oxygen. Sometimes we need to intubate them early. If their H&H is low, we need to improve that as well. We want to restore hemodynamic instability. We're given volume, volume, volume. We need to overcome the dilated vascular space. Oftentimes we do that with vasopressors. But the key here in septic shock is your assessment, because things can change and they can go from warm shock to cold shock and go into cardiogenic shock. So it's that ABC assessment to be able to pick up changes before you're too far down a pathway to know when your treatment might need to change. So reduce O2 demand, reduce how hard the heart has to work, treat our fever. Certainly you want to identify and control infection. And when you think of things like meningeal coccemia, if this is a younger child who comes in with a very high fever, they look very toxic and they have a petechial rash or purpura rash, first make sure that you have your correct PPE on, and right up there with airway interventions or antibiotics for those kids, because minutes matter. Your hemockers are the same if they come in with either a fever or subthermic, and they look toxic and could have an infection. Antibiotics with those kids are right up there with your ABC. Very important to get on that early. And of course, we're checking for and correcting metabolic derangements as well. So cardiogenic shock is pump failure. In general, it's considered cold shock. So in pump failure, cardiogenic shock, they have decreased stroke volume because the heart is not able to squeeze like it needs to. They have decreased cardiac output, which of course means the cells aren't getting what they need. So you have decreased DO2 as well. They could have congenital heart disease. They may be, their actual structure is not conducive to good perfusion. Also recognize that anything that causes prolonged hypoxia, prolonged decreased perfusion, a post-ischemic event can cause cardiogenic shock. They can have acquired heart disease when you think of myocarditis or cardiomyopathy as well. Sepsis gone too long or too severe can cause decreased perfusion to the heart itself, and they can go in cardiogenic shock, which is again why your reassessments and frequent assessments are so important. They could have cardiac tamponade. It could be drugs issues. And as I alluded to earlier, rhythm disturbances like SVT, prolonged SVT, can cause cardiogenic shock and pump failure. So what are our goals? To increase what the cells are seeing, increase your DO2, you want to increase the squeeze, increase the inotropy. You want to decrease the resistance that the heart has to work against, which is the afterload or the peripheral vascular resistance, whether it is actually increased, which can occur, or it could just be relative in that this heart is so weak that any resistance that it has to pump against could be too much. So sometimes we have to decrease their afterload and decrease the workload on the heart. You don't want to pump more into them for them to handle before you're helping them move what they have around. So again, the same thing, optimize O2 content in the blood depending on what they need and what's going on. Improve volume distribution and cardiac output, increase ventricular output and cardiac function. And oftentimes we don't know where on the Starling's curves these kids are when they come in, so we might give them a little bit of volume and a little bit of volume and give it very slowly and observe for their response. We're calling in our experts early on. We might have to consider ECMO if all the other methods are not working, and we might need to consider vasoactive medications as well to increase the squeeze and decrease the vascular resistance. So let's talk about obstructive shock. Again, it's a physical obstruction to circulation. Something has changed in the pathway of blood flow, therefore the cells aren't getting the circulation they need. They can be born with a ductal-dependent lesion, and usually these are babies who are 2 weeks old or less. They have tension pneumothorax, cardiac tamponade, pulmonary embolism. And the basic treatment is for congenital heart disease is palliation of that, or definitive treatment or support until you can. Oftentimes we might have to give a hormone, PGE, that will open up that ductus and keep them perfused until we can do something else for them. But just recognize that oftentimes when you give PGEs, prostaglandins, they can become apneic, so be ready for that. And again, these are newborns, first few days of life, maybe up to a couple of weeks. And these babies can have had good OB care and echoes or ultrasounds and still get missed. So if an infant comes in, a newborn infant comes in to the ER very, very, very sick and dying in front of you, it's usually either sepsis or congenital heart disease undiagnosed. And so rapidly getting to the issue there is very important. They can have a tension pneumothorax, and what are the hallmark signs of a tension pneumothorax, of course, is absent breath sounds on one side and poor perfusion. Because again, this is different between a simple pneumothorax, where the cardiovascular system is not yet involved, and a tension pneumothorax, where not only do they have a collapsed lungs, it's pressing on the vasculature and not allowing the cells to get perfused because of that. So they are decreased blood pressure and perfusion, as well as no breath sounds on one side, tension pneumothorax. Cardiac tamponade, again, their heart sounds may be distant or muffled. Your S1, S2 hard to hear, as well as a narrowing pulse pressure. And the treatment for that is pericardial centesis, but obviously you need to give a simultaneous fluid bolus, because even though their blood pressure is dropping and they have little cardiac output, as soon as someone taps that pericardial sac and it rapidly expands, any blood pressure they had could be tanked. So oftentimes we'll be given simultaneous fluid boluses with pericardial centesis. And pulmonary embolism, often we may take these kids to cath lab and try to do an embolectomy, or we might use thrombolytics, because this is what you're trying to avoid. So in review, in general, hypovolemic shock, you'll notice a very uniform response, peripheral to core or peripheral to central. Distributive shock, they all are vasodilated. Cardiogenic shock, they have wet bilateral breath sounds. They oftentimes have an extra heart sound, a gallop. Their liver could be enlarged. Obstructive shock, it depends on the etiology of what your assessment's going to be. So recognize that the patient is in shock. They have altered perfusion. Oftentimes it's tachycardic, unless, again, like we said in neurogenic shock, where they're bradycardic. Consider the etiology and the history. Begin treatment and reassess frequently in response to those interventions. Are we on the right track? Are things changing? And they can. So paying attention to that, very important. And remember, it's all about supply and demand. Thank you for listening, and I hope you will join us for our classroom presentations on shock in the pediatric patient.